Afternoon, and Happy New Year to everybody, all the listeners, and welcome to our first Multi-Modality Imaging Conference of 2026. So over the next 4 weeks or so, we're going to be having several lectures on the evaluation of coronary artery disease, chest pain, ischemia, which will include all the different imaging modalities that we use for stress testing, as well as looking at the coronary arteries with CT angiography. We're going to start today with the sort of simplest, cheapest imaging technology that we have for detection of ischemia, which is, of course, stress echocardiography. So the outline of today, we're going to start with a very brief discussion on how we assess regional wall motion by subjective assessment. And then we'll jump right into stress echo for evaluation of chest pain and ischemia with sort of a how to do it with case examples. And then at the end, we'll just finish up with some of the clinical scenarios where stress echo appears to be a very cost-effective and accurate method. So you all have seen this slide many, many times, probably starting when you were in medical school, the famous ischemic cascade. So when ischemia occurs, of course, there is a deficiency of blood flow to a certain region of the heart. And therefore, any imaging technology that can detect that should be very sensitive. And that's where, of course, the nuclear technologies like SPECT and nowadays PET come into play. And also CMR is able to do evaluations of blood flow. So any technology that can look at blood flow assessment should be able to pick up this type of disturbance and be quite sensitive. Now, when ischemia occurs, also very quickly, and this has been shown very well in multiple animal experiments way back from 40 years ago, when ischemia occurs, immediately there is some element of regional dysfunction, diastolic and systolic. And this is where echocardiography comes in, is to be able to detect regional dysfunction occurring because of ischemia during some stress modality. You can do that also with CMR, and even the nuclear technology nowadays can assess the wall motion and pick up some of these disturbances. Then you get into the EKG changes, the ST changes, the ST depression, and so on, which are less sensitive because often you may have full ischemia with minimal or no ST changes. And then the worst of all is symptoms. It's fascinating that patients with classic angina with exertion, with effort at home, you put them on a treadmill for a stress test, you get a positive stress test, however, they have no chest pain in the treadmill. So even with all the technology we have today, we still do not understand very well the pathophysiology of pain. And it's a very interesting finding that you put these people on a treadmill, on the supervised conditions, they get ischemia, you are able to make a diagnosis. However, the patient stops because of being tired and never complains of chest pain. At home, they have it. Very interesting. All right, so we're going to then use echocardiography to detect a change or a new development of a wall motion during stress, which indicates ischemia. So let's start first by looking at the regional wall motion. And this is a nice example of ischemia, of not ischemia, of chronic abnormalities in the RCA territory. So we evaluate a regional wall function by looking at the degree of thickening of the muscle, the movement of the endocardium towards the center of the cavity, and we also look for sometimes geometric distortions. And we assess regional wall motion as normal, hypokinetic, akinetic when there is no thickening, dyskinetic when it's actually going the wrong way. We, for example, here might say that maybe this small area here might be a little dyskinetic. And then frankly aneurysmal when you have a big geometric distortion in systole and in diastole. And you can see with the arrows here indicating very nicely the areas that are abnormal in this particular patient. Points to remember: presence of akinesis, hypokinesis, or even sometimes a little bit of dyskinesia does not necessarily mean absence of viability. And we have learned that very well with the use of CMR. So because a segment is akinetic doesn't necessarily mean that all that myocardium there is dead. The other thing that is important to remember, dyskinesis does not mean aneurysmal. For you to make a diagnosis of an aneurysm, you need to have a geometric distortion in diastole in that particular segment. All right. You're all familiar with the 17-segment distribution and the different coronary arteries that relate to that, and the fact that the circumflex and the RCA do share some potential territories in the posterior and even sometimes the posterolateral wall, depending on which of those vessels is more dominant. The wall motion score consists of assigning a simple numerical score to each of these abnormalities, going from 1 normal to 5 aneurysmal, adding all of them and dividing by 17, and that gives you the wall motion score. So we get to this patient here that we showed before. This area here is hypokinetic, so those will be 2. Everything here looks good, so those are 1. And we have then some akinesis and hypokinesis here. That gives us a total of 24 divided by 17 and a score index of 1.41. All right, so with that brief discussion, the name of the game here is you stress a patient to try to induce ischemia, and then you're going to put side-by-side images using digital technology to be able to compare the global function and the regional function in the patient at rest and then during the stress. And these are the common views that are used: parasternal long axis and short axis, and then the apical 4 and the apical 2-chamber view. And with good quality of images, you can certainly see every distribution of the coronary arteries. Now, the truth is that, in fact, when we started doing this in the early 80s, we only were doing apical views. And the fact of the matter is that if you have a good 4-chamber, covering pretty much the RCA and circumflex. Nowadays, we do include the parasternal views, and quite often they can be also very helpful. So, starting immediately, what is the name of the game? So this is a normal patient, and notice that in this normal patient, you cannot see the pointer, so let me see if I can get to put the all right. So in a normal patient, notice that the cavity gets smaller with stress, end-systolic. The end-systolic size of the cavity is smaller because EF improves. And then every area within the ventricle with stress is smaller than at rest. If you look at this patient here, you have very nice wall motion and shortening at rest, but notice how this distal area of the ventricle is now bigger after exercise or during exercise. This particular patient is a treadmill, so this will be immediately after exercise. So this is one of the first things that you're going to be looking for is the size of the cavity at end systole, and do you have any regional dilation in systole compared to the resting picture. All right, stress echo is over 40 years old. So this is a very well-established technology, well accepted, and the indications are very similar in terms of chest pain to those of nuclear techniques. When we look at the appropriateness criteria, they're very similar with many of the scenarios that we see, even patients with relatively low pretest probability, if they have an EKG that is not very clear. And once you get to intermediate pretest probability for CAD, stress echo is pretty much appropriate for most scenarios of chest pain. So what are we looking for? We're looking for a transient, i.e. reversible, systolic, because we are not doing regional diastolic function yet, a systolic abnormality that is new and transient because it occurs with the stress and eventually gets better as the ischemia disappears. Now, that particular regional dysfunction may last a few minutes or even hours if you're in the animal laboratory and you occlude an artery for just 1 minute. When you release the clamp, that segment may be hypokinetic for hours. So that's, of course, well known, the stoning phenomenon. So in fact, when we do the treadmill technique, we are depending on that stoning phenomenon to be able to pick it up, as we will see in a minute here. So with exercise echo, particularly using the treadmill, ischemia typically lasts between 1.5 to 3 minutes post-exercise, giving us a little time to catch it once the patient is back lying down. This is a very old example from the 1985, but still is a nice example of severe ischemia. Notice at rest, very nice end-systolic cavity size, now, short axis, very nicely. And yet, immediately after in the treadmill, look at the short axis, how end-systolic cavity has gotten much bigger compared to rest. And likewise, here the same thing. And then you go to the apical views, and you have very nice end-systolic cavity size at rest with a good EF, and immediately post, there is an increase in end-systolic cavity size and a drop in ejection fraction. So this is a very positive stress echo test that indicates significant ischemia. It could be a proximal LAD, it could be a multivessel disease. And this is just another example to start looking at the how-to of doing this, okay? The practical tips. So when you look at a stress echo, don't go first to look for regional changes. First, look at global. Look at how the EF appears to behave. Is it a flat response? Is it worsening EF, or is it improving EF? Pay attention to the end systolic cavity size. End systolic cavity size. Here you see, again, at rest, a very nice now, and now when you do it here, the EF doesn't look too bad. However, look at this regional, this area here towards the distal part of the LV, now, and look at it here. Now. It's bigger. Go to short axis. Look at how small that cavity look at end systole. Now, look at it now. So we have had an increase in cavity size, particularly regional. You can see it very nicely here. Look at how small that distal portion of the LV looks at end systole. Now, and look at it here. So that you start getting used to looking at those changes can help you identify ischemia. Then you start looking at the segment itself to see whether it is in the LAD territory, RCA, or so on. So what kind of protocols do we have? Well, the one used 90% of the time everywhere is the treadmill technique, using the standard Bruce protocol, and then doing imaging before and immediately after exercise. We're going to also talk about bicycle stressing because it does have a lot of nice things, and we should be using it more often. And then the pharmacologic techniques, which of course is Dobutamine, with sometimes the help of hand grip. Vasodilators are used, of course, for all the nuclear techniques, but in the US at least, it's practically not used at all. And atropine, very helpful to increase the heart rate in patients getting a dobutamine stress echo. And hand grip also can be a nice adjunct when you're doing a dobutamine stress to increase blood pressure even further and try to induce ischemia. So the post-treadmill technique, what are the advantages? It's a standardized protocol. A Bruce treadmill has been used for decades. Almost every practice, office practice has a treadmill, and it's easy to do. Now, the limitation is of all the stress echo modalities, this is the most challenging for the sonographer. It's quite sonographer intensive. This is not where you start your sonographer practice, learning how to do stress echoes. because it's a very, very intense. You get your resting images. When the patient jumps out of the treadmill, you know you have 90 seconds to get it well. And therefore, you have to not only get images, but you're trying to reproduce the same tomographic planes that you had at rest. And that is not always obtained. Sometimes when you put them side by side, you notice that they're not exactly the same. So it's a very challenging technique. And this is, if you want to talk about what's the number one Achilles tendon of stress echo, particularly with the treadmill, is the importance of expertise on the sonographer part to be able to do this. Now, the other limitation is you only have two stages, rest and post-exercise. And you will see that for the average patient, that's great. But there are scenarios where that can be a little bit of a problem. Now, the best accuracy, like with any type of exercise stress test, is obtained when the patient reaches 85% of their maximal predicted heart rate, and the post-exercise images are obtained within that 90 seconds of post-exercise. Now, some patients may have ischemia for 5 minutes, but if you want to try to do the majority of patients, you want to be with that window of 1.5 minutes. The heart rate at the time of imaging is of no importance. I see sometimes people making comments that heart rate was not optimal. No, that's not true. It's the heart rate during exercise. So if you're imaging and by now the heart rate has dropped to 100 because the patient has a nice response, no problem. It's the heart rate at the time of maximal treadmill, not the heart rate at the time of the imaging. All right? Okay, a little bit of a historical point. This is 1983, and this is the paper that puts treadmill stress echo on the map. And it was compared to, in those days, radionuclide ventriculography. And there were 73 patients, and they had, in that initial trial, a reasonably good sensitivity and specificity against coronary angiography, using 70% stenosis or greater. And we'll show you why in a minute. Then 2 years later, in a few years later, in 1992, almost 9 years later, we had another study that was a landmark, which was a head-to-head comparison of 289 patients, where in the same treadmill, with the same exercise treadmill, the patient underwent both the imaging with nuclear, using thallium at that time, and stress echo. So we found a very nice agreement, 88% agreement between the two techniques, with the interesting observation that sometimes when one was abnormal and the other one was normal, about 80% of the time, it was a correct call when we had angiography to compare with. And likewise on the other side. So in other words, sometimes one picked up something the other, and when we had the coronary angiography as a backup, it was a correct call. So again, it just shows that no technique is perfect. And this is a subgroup of 112 patients that did have coronary angiography. And again, you can see very similar detection of disease by both techniques. Very, very similar sensitivities and specificities. Now, notice that for one vessel disease, overall, okay, both were in around 60% sensitive. But when we use 70% or greater, both jump to 85%. And this, between 50 and 70%, has been a limitation of all stress testing modalities. PET probably right now offers a little more advantage. But in that intermediate 50 to 70% of diameter obstruction, it's a gray zone, where of course part of the limitation is our angiographic ability to actually measure that correctly, and the other limitation is that some of those lesions are not flow limiting, so the patients don't actually get ischemia. So that's why, particularly with single vessel disease, we still like to aim towards detecting 70% stenosis or greater. Now, years later, in 1998, there was another landmark paper, which was basically a meta-analysis of over 3,000 patients, and where they studies that had compared both techniques in a meta-analysis, and again, very similar sensitivities and accuracies for both the stress echo and the stress nuclear. We took that group of 289 patients that I showed you earlier, and we followed them for 5 years. So this was published in '98, showing again that both techniques had very similar prediction of outcomes. So this was using, for echo, a wall motion score less than or greater than 1.4, and for nuclear, a 15% defect, less or more, showing that the milder degrees of ischemia or no ischemia had a very good 5-year survival curve versus those that have greater ischemia had a very similar reduced outcome. Another advantage of the treadmill is that you still have all the other things that you do with the treadmill. So you have the duration of exercise, whether the patient got symptoms, yes or no, and of course the EKG. So in 2003, we published this paper where we combined all of that. So we created a risk index, which is using the exercise wall motion score index and the ST changes in the EKG and the duration of the exercise. And you can see that as the risk index increased, the degree of events increased significantly. So that's another advantage of the treadmill. In fact, we still have situations where we do a stress echo, the images look normal, but the patient gets 3 or 4 millimeters of ST depression, they only stay there for 3 minutes, and we still in the report say, hey, take a look at this patient, do something else, even if the images didn't show it. And that's because of still, although less sensitive, you still have the power of the EKG, particularly when you have a very significant change. Bicycle came a little later because it's hard to do a stress echo in an upright bike. So it wasn't until the industry developed nice supine bikes that could also incline enough to give us good images that bicycle stress echo started to pick up. Now the big advantage of bicycle is that you can do rest, intermediate levels of exercise, like 25 and 50 watts, and peak. So now you can compare your peak not just to rest, but also to intermediate levels, because you should have improvement of function with the lower levels and then worsening of function if ischemia occurs at the higher levels. And this is a nice example. So I'm going to let you see that one. Again, use all the tools that I have been repeating multiple times. Look at the end-systolic cavity here at rest, 25, 50 watts, now, and at peak, okay? So, my first question, just raise your hands. How many of you think that this is normal? Okay. How many of you think this is abnormal? Okay. All right. How many think that this is abnormal in the LAD territory? How many of you think that this is abnormal in the RCA territory? How many of you think this is abnormal in the circumflex territory? And the rest of you think it's abnormal, but you have no clue? Okay. All right. So let me see if I can play some tricks here. Okay, it worked. So look again here, now, and look at this area right here, the regional size right here. Now, and look at here. Clearly, this is bigger. Okay.
Can I see the pointer, Doctor?
Oh, I lost the pointer. Interestingly, when we switch, I lost the pointer. Okay, so I have to go back to the other one. Okay, so see this area here, now, compared to now. And of course, I think my next one is just to put the arrow. So this is the area of post-stress abnormality, and that would be, of course, a circumflex territory. Could be an OM. It could even be a diagonal, or because it depends on the anatomy. But certainly, it's that portion of the lateral wall, which is usually even in people with dominant rights, they tend to be circumflex. But again, if you have a dominant right and you get this abnormal, then the inferior wall will also be abnormal. One of the landmark studies that were done with bike was comparing to treadmill, and this was a tough study to do because we asked the patient to come in twice, to come in one day and get a treadmill stress echo, and then come in another day and get a bicycle stress echo, and then they all went to the cath lab. So these were people who were already on their way to a coronary angiography. And again, it showed a couple of things. Number one, heart rate and blood pressure behave differently on the supine bike versus the treadmill. So as expected, you get a much higher heart rate on the tread than you get on the bike, but then you get a much higher blood pressure, so that the double products are similar. That's why when we do a supine bicycle stress echo, we don't pay attention to the heart rate. Do not put the sentence that the heart rate did not reach, because few patients reach. The important thing is, did the patient get a 22,000 or greater double product? If the patient went over 22,000 double product, you have a good test. If they didn't, then you may have a submaximal test. But ignore the heart rate, because very few patients will get a heart rate of 140 or 150 on the supine bike, particularly the elderly patients that we tend to do more elderly people in the supine bike than young people. So it's the double product that counts. Now, when we look at the statistics compared to coronary angiography, very similar for both of them, very similar. One big advantage of the bike is a lot easier on the sonographer. You are right there, and you can be taking some time to do the imaging. Much easier in elderly patients, which may be a little scared of being on a treadmill. You put in a supine bike, it's much more comfortable for them. Very good for patients with dyspnea, because in addition to ischemia, we can use Doppler technology to look at diastolic function, pulmonary pressures, and so on. So it adds all this other important information that sometimes can help us a lot in taking care of patients and making a good diagnosis. And then it has one advantage too, that it is, if the patient has some resting abnormality, let's say that a patient has a little bit of a resting abnormality, or even a little bit of a lowish EF, you are going to see what happens with low level of exercise. And actually, you may see some improvement in function at the low levels that then worsen at the highest level. So by having all those intermediate levels allows you to get a much better handle at the presence of ischemia. In addition, when you're doing your comparison, you don't have to compare only to rest. In fact, the best comparison is your peak stress to an earlier level of stress. Because in that earlier level of stress, the heart should be actually doing better, then it worsens with the peak stress. So it makes your eye actually picks it easier, because you're comparing to a level that already shows an improvement in function. Again, using all the clues, this is a regular post-exercise treadmill. I'll give you a little bit of time. Whoop, what happened? Stop working? No, don't do that. There we go. Okay, normal or abnormal? Normal, raise your hands. Abnormal, raise your hands. Okay, and the rest are insecure. That's okay. For those who voted abnormal, is it LAD? Circumflex? RCA? So what is it? Huh? Okay. I can see where, yeah. This is a nice. These are all studies, and it's a nice example of why we use more contrast these days. Yeah, yeah. No, I can see that for you, this area here is hard to pick up. But actually, the very definite abnormality is here. Look at how this is thickening. Now. What about this one? Is it thickening? Yes. But when? Look at the mitral valve. Now, 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 now. What is this? This is a classic example of post-systolic thickening. In fact, if you're in a dog lab and you occlude, let's say an LAD, the very first thing you see is post-systolic thickening. It doesn't last long. If you keep occluding, you get full akinesis. But before you get the akinesia, you're going to get post-systolic thickening. So during systole, it doesn't thicken. But during early diastole, the LV pressure is dropping, and then that segment is able to thicken. So it thickens in early diastole, and the beauty here is if you keep your eye and watch the mitral valve, you see that now is when the valve is beginning to open. So this is, although it's an old study, it's a very nice, pretty example of ischemia causing post-systolic thickening that you don't see at rest. See, at rest, it's thickening nicely during systole. And this patient had a single RCA lesion, very tight RCA. All right, dobutamine. Not one of my preferred stress techniques, but it's there, as there's still a lot of people that use it. Basically for people who cannot exercise. The problem, and it's the same thing, you can do one or two protocols in terms of the images. You can either put your resting, then a low level, a higher level, a peak dose, and a post, or you can do rest, low level, another intermediate level, and then the peak. I don't know why this one is not playing, but not important. Now, same thing. Everything I've said, you keep saying, you keep doing. You look for end-systolic cavity size, it should be smaller at peak. You look for regional dilation at end systole. You look for comparison of the peak with low stress, just like with the bike. So you compare these two much more than these two, because this should have gone much higher, and then this could go worse. Now, this is a normal, so everything looks good, okay? But notice how small that cavity is, okay? Now, this is one that also has a little bit of circumflex abnormality. So the same story, the cavity gets, this is just a little area. Let me see if I can do the same trick of maximizing it. What happened here? Oh my goodness. All right. Whoa. It had a mind of itself. Okay, so where are we? We are at this one here. Okay. All right. Oh. Okay. What do we do?
Let's see. There we go.
Okay. All right, we're back in business. So yeah, this is another one that has a circumflex lesion, and it's the same story, okay? Look at end-systolic size, look at full size. This actually, with the use of contrast, was a pretty nice study in terms of detecting this area here. And this is the most classic, okay? You know, LAD lesions are always easier than the others because it involves a larger territory and you have the apex involved. And again, the same story. Now you see the end-systolic area here compared to here where clearly is dilated. And in fact, the whole cavity is dilated at end systole, which means a drop in ejection fraction. So these LADs are always a little bit easier. What about this one? This one is interesting. I don't know if you can all pick it up. I'm not going to try that trick of magnifying anymore. Let me just get the laser pointer. So this one is more interesting because what you have here is, and I think you can see it very nicely here. Now, look at it compared to here. now, 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 now. So the whole cavity has become bigger at end systole, which means EF dropped. But do we see any distinct regional change, or is it the whole cavity? Look at the short axis. Now, 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 and look at it here. Now, now. So there's been a dilation at end systole of the whole cavity, but we're seeing it pretty much in all the segments. So this is basically a global drop in EF with stress. And we'll get to that in a minute. So dobutamine, biggest advantage is that it has a multiple stages that you can image during the stages compared, similar to the bike. This is where you will start your sonographer. If you're in a training modality, training sonographers in stress echo, dobutamine probably is the easiest for all of them. And then from there, you could move to a bike, and then you leave the treadmill for the final chapter of the training. However, it is less sensitive than exercise, particularly if you don't get the heart rate to 85. That's where atropine comes in. But the biggest problem is that the LV frequency gets very small. And it's hard to evaluate wall motion when you have a tiny cavity, particularly in LVH. So sensitivity is a bigger problem with LVH. You have a lot more arrhythmias, which can make your life complicated in trying to look at wall motion. And you get no data, of course, in terms of exercise capacity for a patient. EKG is worthless because very few people with dobutamine get any ST changes, even if they get significant ischemia. And nowadays, because we have nuclear techniques, now PET and everything, we rarely ever use dobutamine anymore for the traditional evaluation of someone with chest pain. I think we still use it for some of the heart transplant patients and so on. So, summarizing, detection of ischemia, typical findings. The most important is a regional abnormality that we pick up usually by looking at end-systolic dilation in that region. And of course, then you start looking for the geometric distortion and so on that happens with hypo or akinesis. EF should go up. It tends to go down if you have significant ischemia. It might be flat. The problem is that there are also some elderly patients that you put on a treadmill or a bike, and they still have a flat EF response with no regional abnormalities. So having a flat EF response without regional abnormalities is a challenge in terms of what do you say in your final conclusions. My own personal bias is I've seen so many elderly people that don't get, and I'm talking about complete normal EF at rest. So they are 60, 65, and stress 60, 65. You don't see much of an improvement, but everything okay, looks okay otherwise. Personally, I don't call them as ischemic. Some labs do, some other people do. If you do, you know you're paying a price of a lot higher poor specificity. So you have to make a decision in that subgroup of patients, or you switch to a different test. I have not mentioned, but left bundle branch block is a problem for any modality, because with left bundle you get pseudo abnormalities of regional function in the LAD territory, and it creates a lot of false positive, and it not only affects stress echo, but it affects also stress nuclear, particularly with thallium or pyrophosphates. I think right now, if you have a left bundle and you need to look for ischemia, in my own view, the test to go to is PET, because even the standard nuclear will have problems with left bundles, and such an echo definitely has it. Now, if you have a global drop in EF, then what are you dealing with? It's not normal. It's an abnormal response. But you're either dealing with really bad CAD, left main or multivessel, or a cardiomyopathy. And obviously, those are very abnormal responses that you have to put in your report and make recommendations as to what to do next. And this is a nice example. This is a 45-year-old lady. And again, you all can see in the parasternal long axis, now, compared to rest. Now, short axis. Now, compared to peak post-treadmill. Now. And in the paraepical views, the same thing. So at rest, you don't have a great EF. At rest, you are around close to 50. So you have sort of a low normal at rest, and then it clearly goes downhill in the treadmill, okay? Patient only went 3 minutes. She got short of breath, okay? She got, let's see, her peak exercise, 176, okay? Blood pressure, 153/64, and a pretty good double product. So CTA was normal, and her history was a patient that had a large B-cell lymphoma. She had received adriamycin exposure. So this is probably a relatively mild cardiomyopathy that you could see that with the impact of exercise and blood pressure increase and whatnot, she showed a reduction in EF. And in fact, it's not the first time that we pick up some cardiomyopathies with the stress echo that had not been picked up earlier by whoever was seeing the patient. You have seen a lot of contrast so far. So suffice it to say that we do use contrast a lot. You saw this case already. I showed you this patient because of the nice LAD abnormality. But look how nice this is here. I think probably a high school student would detect it. But look at how tough would be here. Again, this was one of the pivotal studies that put contrast in the map for stress echo, which involved the patients coming twice and getting dobutamine. This was with dobutamine. Dobutamine stress echo without, and then again with contrast. So we owe a debt of gratitude to those patients, and they of course had coronary angiography. And the findings were very interesting because they showed that where you get your money is when at rest you have more than 2 segments that you don't see well. In that group, contrast clearly improved the accuracy of the stress echo compared, looking for disease compared to angiography, 100 patients or so. If you have perfectly nice looking images, it didn't help at all. And even if you have only 1 or 2 segments that were not that well seen, it didn't really help that much. So we do a lot of contrast in our stress echo techniques, but it's because we are in Texas and we have a lot of patients that at rest you don't have full evaluation of all 17 segments. But if you have a very nice quality resting echo, don't use contrast. In fact, contrast sometimes can make your life more difficult because you can introduce some artifacts. A few words about strain. It would make sense that we should be able to use strain for detecting ischemia during stress. Obviously, it would be very hard to do in a post-treadmill or even a bike. So everything that has been published with strain has been with dobutamine. And you all have seen this before, which are the classic bullseyes, abnormal bullseyes that are associated with lesions like LAD here, RCA, and CIRC. And this is one example of a patient let's see. Yeah, this is an example of a patient that underwent a dobutamine stress with a relatively normal bullseye at rest, and then with peak stress, you can see this area of abnormality from an LAD lesion. Well, this has been done, and if you look at the literature in 2019, you find 13 studies with almost 1,000 patients. And the bottom line is that with good quality images, the strain imaging compared to a visual assessment by a separate observer was superior. So strain actually picked up more sensitivity in picking up lesions compared to the visual. Here you see 92 versus 83. So the problem is, this is your ideal scenario. Very nice quality images. For the sonographers, you could, because dobutamine stress is not such a hard test to do. So you could do some strain. Then when you're doing dobutamine, you get your peak stress images. And then since you have about a minute and a half of post-stress ischemia, once you're done with the regular 2D imaging, you could switch to the strain and see if you could detect some abnormality. But you need to have some really nice quality images. And you cannot use contrast. Right now, except for one company, there's one company now that allows some strain to be done with contrast in the cavity. But pretty much all the machines that we have and all the ones that are generally have by most people cannot manage contrast and strain together. So for those reasons, there is really not a lot of use of strain today in stress testing. All right, so putting all this together, what are some sort of facts that we can talk about in terms of stress echo? First of all, it is an accurate test for detection of ischemia and coronary disease. Its accuracy, however, depends on expertise of sonographers and, of course, interpreting physician. But the sonographer is key. You are the captains of the plane on this one. The accuracy of stress echo is limited in patients with left bundle and also in people with depressed EF and abnormal resting wall motion at rest, unless you use either dobutamine or bike. But on a treadmill, it would be very hard to know what you're dealing with because you're already starting with something abnormal at rest. Dobutamine is less sensitive than exercise echo. And in today's world, when we have such easy access to nuclear technology and PET and CMR, personally, I seldom use it. I know that there's some of my colleagues that still order it, but I particularly, if I have a patient that cannot exercise, I would rather go to a nuclear technique. So how do we choose the best modality? Well, again, I think you're getting the message. Somebody comes in with chest pain, and they're relatively healthy, and they can exercise. Stress echo is the most cost-effective and pretty comparable in accuracy to all the others that are a lot more expensive. Bicycle can be a preferred technique, particularly in the elderly people who are more scared of a treadmill, and sometimes in people with regional wall motion abnormalities at rest, because you can see what happens during early stages and then peak stress. And dobutamine, okay, would be deferred for people who cannot exercise, but I already gave you my own personal bias about it. So this is a very typical scenario we see in clinic every day. Somebody comes in with chest pain, angina-like, they have intermediate or higher risk. These are all your choices, and clearly exercise echo is the most cost-effective of all of them. Likewise, if the patient is very morbidly obese or have left bundle branch block, personally, this is now becoming my preferred technique. You're going to be hearing about both of these in the upcoming weeks. So advantage of stress echo, low cost, no radiation, and also a very important thing, you get results right there. You don't have to do a lot of processing, you don't have to do, basically, you take a look at your result right there, and you can write your report. I mean, you don't have a lot of post-imaging processing stuff that you have to do. So thank you very much for your attention. We have a few minutes for questions. Davis, you're always asking questions.
All right, I do have one. Is there anything like a TID ratio for stress echo that's been published as to what a cutoff is considered for dilation?
Nah, it's your eye. But I hope that what I show you were clear enough that you can pick this up, particularly when you have the advantage of contrast. I mean, you can really see nicely how you get that regional dilation. You don't always get global, but you often get that regional area where the ischemia is happening, and it doesn't quite make it in terms of end systole compared to at rest. So but no, there is no numerical standard, like X% or anything like that, no. Because it has been really an eyeball type of evaluation. Any other questions? All right, I think next week we pick up some of the nuclears.